program on your app. You can download the app from anywhere. The app also has a voting system where you can vote up till 12 midnight. So it's not only the judges on the panel here, but also the public which can vote for the best cases and for the award sessions. Also, for the first time, we are having a preloading kiosk, which we are going to be launching today. Dr. Amal Banerjee is going to do the honors a little later. And this is a kiosk where you preload your slide, you get a unique ID or a barcode. You just have to come here and scan your barcode here, so you don't have to select your slide. Automatically, your presentation is loaded. So it's all automated, and the first time we are going to start this technology anywhere in the world. So these are the new things which we are going to discuss in NIC, and most important is, with the help of all of you, we have been able to collect data from 630 centers across India, which is a tremendous increase as against 396 centers last year. And tomorrow we'll have the data presentation, so we invite all of you to come there. Thank you very much.
Thank you very much, Professor Khanna. Ladies and gentlemen, that brings us to the end of this brief inaugural ceremony. We would like to thank our dignitaries and request them to kindly have their seats on the floor. We move on straight away to the first session. That's the live coming up. We've got it for the next 55 minutes. Before I invite the chairpersons and members of the expert panel, we have both the institutes going live, the Lisie Heart Institute and the Apollo Health City going live simultaneously. And we'll take the audio feeds one after the other. The first 20 minutes would be for the Lisie Heart Institute, followed by the next 20 minutes for Apollo, and the last 7 minutes each for both of them to wind up. We will have a total time of 55 minutes, after which we would be delinking. With these few words, may I straight away invite our chairpersons. Please welcome Drs. P.K. Dev, Suman Bhandari, A. Srinivas Kumar, members of the expert panel, Dr. Saroj Mandal, Naga Mallesh, Rakesh Gopal, Anand R. Shenoy, B.G. Murlidhara, and Samir Pagad. Please join the proceedings on the dais so that we can have the things in place. I'd request Professor K. Venugopal to kindly join Dr. Srinivas Kumar in the course of the proceedings here, and Dr. Minal Kanti Das as well. Can we go live to Lisie Heart Institute, where Dr. Rony Mathew Kadavil, the Chief of Cardiology, is awaiting us? Yes, there he is there with Dr. Jabir, his colleague. I'd request Professor Venugopal to kindly establish contact with him, along with Dr. Srinivas Kumar and other members of the expert panel. As we just pass on, we will have only the moderators and the panel who will interact with the operators. Anybody from the audience who would like to clarify can come on to the stand-in microphones and they will be connected.
Good morning, Rony. Can you hear us, please? Rony, this is Venugopal from Hyderabad. Rony, Jabir, can you hear us? Audio. Can you check the audio, please?
I'd request Dr. Hiremat also to kindly join the proceedings on the dais, along with Dr. Das. Okay. I'd also like to invite Dr. P.P. Mohanan from Thrissur to please join the elite panel. Can we have the audio on of Dr. Rony Mathew for the chairpersons? Can Dr. Srinivas Kumar or Professor Venugopal establish contact?
No. Dr. Rony, can you hear us?
All right. Good morning.
Yeah, can you increase the audio volume a little?
Yes, we can hear you. How are you?
Yeah, fine. I'm Dr. Srinivas Kumar, along with my other colleagues here. Dr. Venugopal, you have already heard. I think
Dr. Ven,
we are able to see and hear you well, so please go ahead and present your case.
hi. Good. Good. We'll start off with our case. And let me first introduce my colleague, Dr. Jabir. There is Sister Betty over here, and there's Dr. Vijay, whom we can see. If you can see, come here, Vijay. He will be our OCT expert for today. Now, let me come to the angiogram. And before we come to that, Dr. Jabir will present the case for you.
Good morning and greetings from Lisie Hospital. Can you hear us, Venu sir?
Not
Hello?
I think you
I think you go ahead. They're trying to adjust the volume, but you can go ahead.
Yeah. Right, this is a 49-year-old gentleman who is a head load worker. He is not a diabetic or a hypertensive. He presented to a nearby hospital with chest pain and referred to our institution for further evaluation and management. When he presented to our institution, he was in cardiac arrest. He presented to the emergency department with cardiac arrest, and you can see the electrocardiogram, which was a ventricular fibrillation. He was resuscitated, shocked, ventilated, and there itself, in the emergency room itself, he was given the thrombolytic therapy with a 10-hectare place. Then he was managed, shifted to the CCU, managed, extubated on day 2, and an angiogram done on day 2. We'll show you the echocardiogram on day 2. This is the day 2 echocardiogram. And over to Dr. Rony for the angiography.
Right, let's run the angio. Good. So as you can see, we have a LAD D1 bifurcation disease over here. True bifurcation, Medina 111. And of course, we are going to do a bifurcation stenting, but before we do the bifurcation stenting, I have run an IVUS and an OCT, and I'm going to show you how these technologies are going to really help us in planning this bifurcation and executing this bifurcation. So before we decide on the strategy of bifurcation, let me just go to the IVUS pictures and show you some of these IVUS pictures. Jabir, can you tell us the IVUS pictures?
This time we are using a particular IVUS technology. I think perhaps for the first time in NIC we are showcasing these new facilities from the volcano. We are having the core register IVUS imagings, core register technique, where you are registering it along with the correlating with the angiographic findings. Previously we had a disadvantage of finding out where exactly the point we are looking at, but now there is no issue. We can, wherever you want to put the sample volume, you can put it and see. Could you show the bifurcation? Prashant, could you show the bifurcation? You can exactly show the bifurcation area, the IVUS images. No, this is another thing that is a new facility that is provided by the volcano people. That is the vessel enhancement technology. You can see clearly the bifurcation where you can see the side branch doesn't look that significant, but if you come to the other view, please go to the LAO-caudal. You can see it's a tight disease. LAO-caudal. You can see here, you can see the LAO-caudal. It's a tight disease of the diagonal ostium. So could you go again to the core register images, which helps us to actually decide on what is the size of stent you require, how long will be the stent, and all these things. So could you measure and tell us, could you show the measurements? So here proximally, show the measurements.
Around about 3.5.
Its exact measurement is 3.2 at the proximal area. Show the measurements. Yeah. Prashant, show the measurements. The core registered images.
He doesn't have that.
Fine.
Okay.
Okay, good. So we measured it. It was 3.2 to 3.3 in the proximal area, and the distally, that it has come. It has come. It is 3.4, and distally it is 2.8, and the length is around 28 millimeters. So you can get an exact measurements, the size as well as the length of the stent you needed.
Now, before we again talk about the strategy of this, I want to show you the IVUS pullback which we did. But of course, to do the IVUS pullback, we had to do a pre-dilatation because the lesion was tight. So we did a 2 millimeter dilatation, and then subsequently, please show me the next angio image where we can show the fluoro. Show me the next shot. Next angio. Next, yeah. So we wired, of course, we had to wire. Next one. We wired both the vessels, LAD and D1. Next. And then we had to do this pre-dilatation, as I said, to run the IVUS inside and the OCT because the lesion was too tight. Next. Next. Now, this was the IVUS pullback where co-registration was done. Next. That's again IVUS. Now this is the IVUS pullback. We use the OCT pullback, where we use the Dragonfly Duo catheter. Now let me ask Dr. Vijay to talk about this OCT pictures that you are now going to see. Can you get the OCT onto the bigger one, please?
So this guy had heart failure.
Not IVS, OCT, please. Yeah, that's it.
Failure and LV dysfunction. So this, we wanted to reduce amount of contrast. So we tried to use both the technologies, IVS and OCT, for planning our procedure. So this now what you are seeing is IVS pullback from the side branch. The side branch diameter at the distal landing zone is around 2.5 millimeters. And you could see a lot of calcium in the side branch ostium.
Nitro.
So we prepared with a 2.5 NC balloon before putting our stent. So that is side branch preparation. Just now we go to a main branch OCT. Just play it. Just go from distal and play. And just show the angiogram together. So this is the latest version of OCT from St. Jude, which we did it used a catheter called Dragonfly Duo. The advantage of this Duo catheter over the previous version is you can just see the angiogram images now. Could you just play? You can just see a marker moving along the pullback. So you can exactly see where you are in the angiographic frame when you review your OCT images. So we have started beyond the third septal. You could see 3 septals in your angiogram. So we have started well beyond the third septal, close to that bend, and come back close to the ostium of the left main. Could you see the pictures now?
Yeah, they are seeing it simultaneously.
You can see the pictures. Can you move frame by frame? And if you start distally, so this is where we have started, well beyond the third septal branch, and just coming, this all relatively okay vessel with some intimal thickening. Otherwise, you could see all 3 layers. So it is a reasonably good vessel for landing. Just you can just see here is coming back. Yeah, I'm just coming back. Just see everywhere it is reasonably good vessel for your landing. So distal landing is not a problem. Beyond the third septal, wherever you want, you can land. And just coming back to the lesion side. Strangely, initially when we did the angiogram, we all thought it is only a ruptured plaque with a soft lesion with a lot of thin cap fibroathyroma. But the finding what we got from OCT was totally different. You can just see I'm coming close to the diagonal branch here. This is our diagonal, and it is proximal to the diagonal now. So,
can you show the extent of calcium, Dr. Vijay?
One minute, sir, just to show them. Yeah. You can just see here, this is our tightest part of the lesion. I'm coming proximally. So from pathological studies, we know that rupture plaque is not at the site of the tightest part of the lesion. It is always proximal to the lesion. You can just see here, could you see the rupture plaque at the 6 o'clock position? So that is the culprit. But actually, you see distally, it is everything is calcium, not much thin cap fibroathyroma at all. Everything is calcium. You can just see around it is about 270 degrees. It's all calcium. The whole extent, you can just see here distally, it is from 4 o'clock position to 9 o'clock position. Everything is calcium. We measure it is about 0.6 millimeter to 1 millimeter thickness. So obviously, you know that even though it is an acute MI patient, you need a lot of preparation before putting your stent. And for some measurements, we just measure the distal landing zone. Distal landing zone is about 2.6 millimeters and came all the way proximal to the diagonal. So it is about 3.5, 3.6 millimeter proximally. So you could start about 3 to 4 millimeter proximal to the diagonal branch and go distally beyond your third septal. So beyond third septal, everywhere it is a reasonably okay zone to land your stent.
I think, Dr.
Right.
Rony, as you have the luxury of having both IVUS and OCT imaging together, for learning lessons for all of us here are basically OCT. We used to think that it is actually measures more superficially, and the diameters we could get are slightly less compared to IVUS. So can you just tell us what are the diameter you got on OCT and what was in IVUS? Because it both look good same here. Length exactly is 28 mm by both. But what was the proximal diameter on OCT and proximal diameter on IVUS?
What are the diameters? Yeah, what are the diameters?
It is around 2.5, 2.6 distally And before bifurcation, that is close to the left main, it is around 3.5, 3.6 millimeters.
Generally for benefit of everybody, the OCT gives a slightly lesser value compared to IVUS because imaging is more from endothelium to endothelium. So if you have to balance out somewhere, probably you would select a size in between these two values. If at all you have to.
Right, Ganesh.
Go ahead.
Good. So now that you have all the data with you, what sort of bifurcation do we do? Now, anyway, what before I ask you a question and you debate over it, I will tell you what we thought about it. We thought that we must go with a two-stent strategy because now you have a large side branch, more than 2.5, 2.75 millimeters. You have a lesion there, it's extending more than 5 millimeters into the side branch. So we thought we'll go with a two-stent strategy. So first we went and dilated both. And subsequently, we thought we will show you a hybrid bifurcation. That is where we put a metal into the side branch and we do something like a DK crush it with a kiss and then subsequently go and put a BRS. So that's what I've done here. If you see on this, I kept the stent don't move until I tell you. Go to scene minus. Right, so there I am positioning the stent exactly at that diagonal. If you can show me this IVUS also simultaneously, the enhanced image, it helps me exactly show that. Can somebody show me the IVUS?
There's the angioplus there. You can see the angioplus.
Yeah. So, right, so show the next one. Then subsequently what I did is next angio. Then I went and flared the proximal part of the diagonal. Next. And then we remove that. I crushed this with a balloon. So this is the first part of the DK crush. And then we recrossed it. Next. 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 Right. And subsequently we did the kiss. And then we did an IVUS pullback to see if the stents were right, kissed and crushed properly at the ostium.
We did an OCT pullback also.
Yeah, so this is the OCT pullback. I'm sorry, I'm keeping on confusing with IVUS and OCT. It's an OCT pullback. So Vijay, can you show us that exact point of the bifurcation where the OCT shows that the stent is adequate?
Yeah, this is the pullback we did after side branch stent has been deployed. You can just see here from 3 o'clock to maybe 2 o'clock to 5 o'clock position, you can see the side branch. Still you can see stent studs here. And there is this, you can see it for 4-5 frames. It is about 1 millimeter of stent into the main, and there's nothing protruding into the main branch at all. So it has been optimally crushed. So side branch is done now. So we are going to do the main branch. And after dilatation, again we just review the main branch. Main branch looks like it's adequately prepared everywhere.
Just time to go and put the BRS.
Yeah, we will put
Open the
and
BRS.
it has been prepared very well. And we are ready for
3.5, 28
stenting now.
BRS.
Right, so good. So we are right now at this stage. I hope you can make that out. So now I'm going with a BRS implantation into the main vessel.
So it is, Rony, it is basically more of a mini tap, just minimal protrusion, then you have crushed it. It's more than, because the OCT images, the stent didn't protrude too much into the main vessel. The idea was to have a minimal protrusion, then cover it up with BRS. But when you expand it, when the metallic stent starts coming into this with BRS, I don't know how comfortable we should be when the stent gets expanded well. All that I think we should take proper care in imaging, see that BRS gets expanded well, especially when the point where the metallic stent protrudes into the branch.
vessel is calcified. You said there's a 230 degrees of calcification.
Absolutely, absolutely. I fully agree with you.
Actually, nowadays, people started putting BRS in calcified vessels after proper bed preparation. That's why I think they did dilatation. Though OCT-wise, it looked like there is amount of calcium, but that is not much when you see fluoroscopically. I think still we can manage doing. But I am a little concerned about this combination of metal stent with BRS.
What we did for the calcification was we saw the
Go ahead.
I know there has been this issue about bifurcations with the BRS, but see, putting two BRS as bifurcations is a little difficult, and especially with this 150 microns around, I think it's a little dicey job.
Shall we come a little backward?
In this situation, I think what has been advocated is this hybrid procedure where we put a metal onto the side branch and the BRS onto the main vessel. And as Dr. Ganesh said, the most important thing in this is actually imaging. You have to be absolutely sure that you have crushed the side branch stent very well.
1 millimeter forward.
Distal.
Distal.
Rony,
Right.
Dr.
Now
Hiramacha.
we will deploy the BRS here. Come.
Want to take a DC?
No. 1, 2.
Yeah.
Yep. Hi, sir. How are you?
Shall I go?
Yeah.
2.
2.
Have we used something like cutting balloon or non-compliant balloon for LED
4.
pre-dilatation?
4.
4.
Especially in view of calcium which you saw.
Yes, we did see on the 6. Yeah.
6, I think
We saw calcium.
6.
8. And what we did is we tried to get a cutting balloon 3 over here. Unfortunately, we didn't have a cutting balloon right on the shelf. So we went into 3 NC. And with the 3 NC, we went to about 24 atmospheres. 10.
Distal.
Doesn't matter. Look at the size. That's okay.
Okay, I'm going up to 10.
I'm doing a slow dilatation of the BRS. Though the size distally showed about 3.3 and the proximal around 3.7, so we have taken something in between. So I'm not going to go very high pressure with this. I'm just going to go at and deploy this at around, right now, around 10. And around 12 atmospheres is around 3.8 if you see. So I can't go further because the distal will otherwise dissect.
It's 20 seconds past.
Negative.
Dr. Rony, I was told that you have another 2
3 and
minutes
C.
to show this, and then we have to switch to other lab,
Right,
and
give
we'll
me
come
a 3
back
and
to
C.
you later for imaging. Yeah, once they finish.
Yeah, so what I'll do is, I will cross this BRS offline and then I'll show you the OCT by the time you come back.
Okay, thank you. Dr. Rath?
Dr. Rath, can you hear us? Dr. Rath?
Yeah. Can you hear me?
Can you?
Hello? Yeah, I can hear you.
Yeah. Please go ahead. Please give your case history.
Yeah. Good morning to all of you. Welcome to NIC Hyderabad. And I'm doing this case along with my colleague Dr. Manoj Agrawal and Dr. Dikshit. With me is our technician Srinivas and Sister Jamna. We have a very interesting case. I'll ask Dr. Sundar to present the case. They are transmitted? Just tell them. PPD used. Anyway, it is just, it's coming?
No, we are seeing you, not the slides.
Okay, fine. Then I'll. Anyway, let me tell you, this is a 69-year-old man who had an intraoral MI 2 months back. He's a diabetic with mild renal dysfunction.
You're able to see the slides now.
Yeah, yeah. Now this is the 2 months back. He was admitted with intraoral MI. That time angio was done. It showed triple vessel disease, LMCA, bifurcation lesion with total occlusion RCA. He was advised CABG. He didn't want CABG, so he just was on medical treatment. Wherever he went, they suggested you go for CABG, but he didn't do it. day after night, he came with prolonged chest pain. So we did the angio and saw the angio. Can you show the angio? And you can see the critical block in the left main, bifurcation, and there is also a critical block in the diagonal with a sizable vessel. And can you go to the right? This you can see is a true bifurcation, left main bifurcation disease. And size of the vessel is quite big. In fact, it's around left main, the proximal part is around 5 millimeter. And LED also around 4.5. That normal part of the LED that we will show it to, we have done the IVS. And can you show the, and no, go ahead, yeah. Then yesterday we did the angiogram. It's a RCA is originating posteriorly and it's totally occluded. And we tried a lot. Ultimately, Manoj could open that RCA, and that RCA had a lot of clots, and you can see that. And this RCA we opened, and the vessel size was good, but there are a lot of clots. We give GP2B3 overnight, and today when you brought him, we checked the RCA first. RCA was just like this, the one you saw, and today we started with today's presentation. Study, you just saw it. Today's study. So the RCA first. That is today's RCA. You can no, that is yesterday's RCA.
Today, sir.
Switch. Okay. Okay, today's RCA was almost same as you see in the last. Then we took the 7F catheter, guiding catheter. We took some shots, and first we thought we'll do a IVS, and we did the IVS. Can you just show the IVS? Show the IVS live. Basically, what it shows that left main, the tightest part, the area is around 4.5, and the clog burden is around 85%, and this vessel size is around 5.5 in the left main, and LED it was around 4.5. And circumflex ostium, there is disease. So you can you see the intravascular ultrasound pictures? Yep. This is the LED, and you are seeing the LED, it's around 4.5, I've checked in the year. Then we are coming towards left main. This is still in LED. This is proximal LED. No, the distal, and that is the proximal LED. You can see the plug throughout. And that is the circ, you can see, left main, right. The circ. There is some disease in the ostium of the circ. Size of the left main is 1, 2, 3, 4, 4.5 here, near the bifurcation. When you come proximally, just then you can see the size is increasing, and left main is around 5.5. And we checked the plug burden is around 85%, and diameter is minimal diameter. Area is 4.6. So this is the things, and can I ask the panelists and experts to give their suggestion, what is to be done and what you think?
Yeah, PC Raymond here.
Yeah, tell me.
I'm sure you have a job on hand, exciting left main bifurcation. The important issue is finally how we achieve the final diameter in the left main. There are many ways in which you can address the bifurcation, but we have to have stent, which is ultimately going to reach that 5.5 diameter in left main. So any thoughts on that as you progress?
In fact, all this I checked. We have a 4mm stent, Alpine, which can go up to 5.5. In fact, most of the 4mm stent, 3.5 also you can expand up to 5.5. Other companies stent like Medtronic also, 3.5 can be extended up to 5.5.
So many times the issue is not having a 5 balloon on the shelf. So
yeah, we have a largest balloon is 4.5, which can go up to 4.9. But we have kept a peripheral balloons. Many times we have done dilatation of the left main large vessels with peripheral balloon also.
So as you finish the case, you bring back the balloon and do a hug. So 2 balloons together in the left main
that is
would
that
probably be able to
probably,
give you a
yes.
bigger diameter.
That's what.
So the important thing is to keep enough metal in the left main. You should not start your stent just where the lesion starts, but keep a little bit of space in the left main backwards so that you can do all these fancy post-dilatations.
Yeah, that's a good suggestion. In fact, instead of using a peripheral balloon, other alternative is to 2 balloon. When you are kissing, bring it back little, and in 1.4 and another 2.5 or 3, it makes around 5.5.
Can we see the images, not the IVUS, PC?
Angiogram. You want the angiogram?
Yes.
Okay. Show the angiogram. Before that.
So what's the syntax score? I mean, I know you're already with your wires in, but...
how much is 20? How much the syntax goes, Sundar?
24, sir.
24.
Good.
This is that RCA today we did it. Before doing, this is the RCA. It's flowing, still there is a lot of clots. And so the left, I just want your opinion about the diagonal. See, the diagonal is a large vessel and is blocked from the ostium. And
Yes.
there's a significant block. So what do you think should do?
I mean, the diagonal will go for provisional side branch stenting. The left main area, of course, get 2 stents, 1 to LED, 1 to circumflex, and diagonal will be provisional stent.
Any other? See, Ulu, so what I have done, just go ahead. What I have done is, I've just did a plain balloon of the diagonal, and the result looks okay. Because I don't want to mess around with 3 wires and stains and all these things. So I thought, first let me dilate with a balloon, 2.5 into 10, and then check the result. And go ahead.
Didn't wire the circumflex?
No, not it, because I'll wire later, because this is through the LED and
So when you do the dilatation to the diagonal, one should be mentally ready that after stenting, you may be rewiring the diagonal. So we don't want any flaps, dissection in the diagonal.
Just show the result last.
This balloon dilatation has to be very, very careful.
Just show the, take out the last injection, next injection, next. Okay, done. See the result. See the result of balloon dilatation. There is no flap. Flow is quite good. Result is, some residual is there, but not bad. See, will you like to...
No. At this stage, PC, I would accept residual lesion, not go for a perfect balloon result on diagonal. We can achieve that by a final kiss in stent and balloon
So
on
you
diagonal
don't, I think this is what I did. I just did a balloon dilatation of the diagonal and left it alone, then put a wire into the circumflex, just so, next. And, no, so the last.
How many would have avoided dilatation to the diagonal and just keep a wire to protect the diagonal as a side branch? Any thoughts?
Yeah, because once you are dilating, if it dissects, you should be mentally prepared to put another stent. That's why Dr. Hiramat was mentioning to do a very slow, controlled dilatation, because if you land up with dissection, then you'll end up adding another stent there.
All right, PC.
Okay, after that we decided we are planning to put a stent from left main to LED. You have seen this, and what do you think about the size of the stent?
So PC, we are going to just discuss here, giving you bad ideas, but you're the boss.
No, it's okay. I welcome all the bad ideas, because these are all, this helps me in shaping the good ideas also. So what I have decided is to stent the left main to LED by 4 millimeter and 23 supine stent, and that's what I am taking it. Can take the hand out, and this is where the stent is going, and just so this, go to this, see, the hand, you just take it out. See, I do not want to cover the stent from the left main, ostium of the left main, but I think little, that's okay, I think, just see. Okay. So
Come
the
back a
PA
minute.
cranial is a 23 millimeters 4. I think that should be okay. Go to this view. Inject once more.
Actually, can come back a little because as
Yeah,
Hiramad
the
mentioned,
inject-
it is better to come to normal segment if you're post-dilating. Yeah, I think that should be okay.
Inject.
Just
Okay,
a
fine. Go ahead. Go up to 16. 16 it becomes how much? Okay, deflate quickly. Quickly.
4.24.
Yeah, I think it will be okay. Then they'll rewire it, then remove it.
Quick. Okay, fine. Pressure, check the pressure. Okay, fine. Give injection. This was go to the PA cranial. That looks okay. So the distal part of the stent, that's okay, I think. So what I think is I'll just take out the balloon and take a 4.5 millimeter balloon and dilate proximal to the stent. So that it will be easy for me to exchange the wear.
So 4.5 for the pot, is it?
Yeah.
This is Bhandari. So you don't want to treat the circ at all?
Oh yeah. Where? That LED wear. Huh.
Yeah, PC, all of us agree that pot is a must under this setting. So
Because pot makes two things. Doing the pot, it makes easier to recross with a wear again to the strut. So the give injection, I want to see it is having pain. Okay, fine. Give me a balloon. Go to this view. Yellow color. Give me the balloon. 4.5. 10. It's better to take a short balloon because what our intention is to dilate near the left main bifurcation and
pot.
Inject. Okay, fine. I think you see the circumflex. I think it's pinched now, and we have to do something for the circumflex. We can't. It's a large vessel. I think we have to stent that also.
what was in your mind when you started? I thought two-stent strategy was always on, right?
I think it was always two stent. I kept it in mind
With
because it's a large vessel, and then there was a disease in the ostium of the circ. So I thought two-stent strategy, two-stent will be required for this. So taking a 4.5 non-compliant balloon, and we'll do the pot with this. Just pull it, bring it closer. Where is it gone? Test. Give, dilate. I'll give some morphine. 12. Okay, deflate. Another where you give it. Give a where. Blue, no. Give me this cyan blue. Can take out this. See the ear and take it out.
So by doing pot, we are actually avoiding the possibility of wire going subintimal.
Yeah.
When we take substrate, rather, when we go into the side branch. So we stay inside the lumen and then access the side branch. Also, the struts open up considerably, helping you to access the side branch more easily than...
You know, the size of the circumflex is quite big. It's around 3.5 is the size of the... what is happening? Not coming out. Okay, fine. So we should go through the strut and dilate well or else the stent will not go.
Dr. Roth, there are some learners also. Could you highlight why you are still not recrossing the wire on the circumflex?
Oh, I'll recross now, but I'll keep that other wire as landmark, so that will help. After I recross, I'll pull it out.
Leaving the side branch wire before you recross is always an advantage, the way PC is doing. It will sort of change the angle and access the side branch much easily.
So it's, I think it makes the, once you keep the wire into the circumflex, it makes the, I think the angulation, so my left main to circumference angulation little straight, then it becomes easier for you to recross. This is the, no.
So this wire you take is a conventional wire, or you take
this
hydrophilic
is
wire?
cyan blue.
Cyan blue.
Yeah.
You went to 16
I
with
went
the
to
wire
16.
inside, so you wouldn't worry about that pressure getting the wire entrapped?
I have been, yes, little that possibility is there in hydrophilic wire, but I have not faced, a lot of people say that I usually do that, but I have not faced this problem.
So you would go to 20, 24 with the wire entrapped?
Not
no,
20, 24, I've gone up to 15, 16.
I'm just asking his
Just,
experience.
No,
When
I
you-
have,
Normally I would worry about 12, beyond 12 with the wire, you know.
I mean, most of the problems would come if that trapped wire is a hydrophilic wire.
Hydrophilic
Sometimes
wires
the
and the
coating
key
may
wires.
come off. So when you trap, maybe you don't trap hydrophilic wire. Not a rule, but convention.
I recrossed, I think I went up to the, you saw, I went up to the circumflex and this is the circumflex where, let's see, it's coming out easily, no problem.
Came out so easily.
Oh, that is because you have a left main 5.4.
Maybe.
If the vessel was same size and going to
Yes,
16,
that
I think you would
just
entrap it.
inject. You know, you feel when you feel sometimes little resistance, but I am not, if you are not using O guide wires, then I have not seen any guide wires slapping, staying where. I have not faced that problem. But I have seen this usually happens in old guide wires, hydrophilic guide wires. So give a balloon, the 2.5 for dilatation of the strut.
So we were actually talking of side branch wire getting trapped, not able to withdraw. I think it rarely happens, once only for me in my lifetime. Maybe I'm lucky. But if it does happen, you can actually put another wire substrate, another balloon substrate with a small diameter balloon, expand it at low atmospheric pressure, the wire will still come out. So it's only when you use O wires, you worry about this because wire can break and then you can have a problem.
Should be more careful when you're putting wire in between two metals, like your bifurcation stenting two metals, then you get a stuck wire, then it's more problem rather than native vessel.
You can always get away, but prevention is the key. So if this vessel was 3 or 3.5 and you are going to 16 with a 3.5 stent, I would worry, because then your gap to the vessel is very less. Here you have a left main 5.4 and you've gone up with what, a 3.5
You're
stent?
getting the balloon?
What's the length of the
Still have
stent
a
that you're
gap.
planning for the circumflex?
You know, this circumflex is,
Still you have a 1
length
millimeter
is
gap.
3.5, just to give you injection. And length I am planning is 18. Just show the PA caudal view. Just go to
There's
PA.
a lesion.
Dr. Rath, I was told you can tell your plan further and then we are supposed to go to the other lab. We'll come back to you
Okay,
again
you
after
can,
7 minutes.
you can go ahead. In the plan is, I'll now dilate the strut,
Yeah.
then use a 3 or 3.5, 18 stent, and then the tap technique, then finally the kissing.
I
And
think,
then after that, I'll do the
The
IVS.
L6 is bifurcating there. I think you need not take too long a stent. You just check that because
I saw, you know, large.
otherwise
just
it
one-
needs
yeah.
to come back more
You
into
see
left
the-
main. Maybe 15 may be okay.
18 is okay, I think.
If it is
15
coming
short.
into, once after the bifurcation, L6 is
Let me
becoming
first,
smaller. I
let
think
me
that
see
you'll
the-
check when you're dilating with the balloon
Yeah,
also.
yeah,
I
that's
think-
what I'll put the balloon
I think,
down little,
I think
then
we'll
I'll
get
be-
back to you,
Yeah,
Dr. Rath,
yeah,
once we see
yeah.
final result in Lisie Hospital,
Yeah,
right?
fine, yeah.
Okay, go to that other place.
Main branch.
So we will go at 552.
Right.
Rony,
So now we will go there. So what you do is just keep this diagonal.
Yes, yes, sir.
Are we on?
Yeah,
we are on.
we are
Can you
able
come
see
back
you
to
now.
us?
Yeah,
Right.
Rony?
So I'll just finish this.
Yeah.
Go to
Two.
Right. So what we are doing is we have implanted the BRS and now we are doing the KISS onto the BRS. Now this is what we call a mini KISS. I'll just come to this. Let me finish this mini
Five.
KISS.
Five.
Five. That's it. Five.
Five.
Only five. Down. Down.
This is again, this technique of dilatation through BRS
Right.
is again important to prevent
now
stent
let me
start
tell you what
fractures of
exactly
BRS.
we did.
Yeah.
Yes. Now, what we did is, can we go back? Now, after we dilated no, not after that, BRS. Show me the BRS point.
Yeah, we left you
BRS,
when we implanted BRS.
Implantation of the BRS.
Next. Yeah, so this is the BRS being implanted. Go next. Right. Now, this is after the implantation of the BRS. Go to the next view. Now, we post-dilated.
This technique, you can see the enhanced imaging, you can see the markers, which is usually a problem with the BRS, but here you can, with this, the IVUS technique, you can see the platinum markers very well to position your balloon. Can see here very well the platinum marker and the balloon just proximal to that, the distal, distal part of the balloon.
Next angio. Next angio.
What technique is that?
So once
Dr.
we
Jabir?
did that, proximal also we
IVUS
did a port with a
co-registration.
3.5. Next. Next.
This is this is the angio plus technique, that is the IVUS technique newly introduced by the volcano.
Next.
Dr. Srinivas, you can hear.
Yeah.
Next. So what we did is we now recrossed the strut of the BVS and then we pulled out the other wire. Next. And then we did a IVUS pullback, which I will tell you if we have time to show exactly. It showed exactly that the wire had gone in the middle of the BVS. And can you just show that image for a second? Can you show OCT, please?
Just to concentrate on the longitudinal view, you can just see at 35 millimeter area, you can just see the wire exactly passing through the middle of the BRS side branch. So that has been confirmed with OCT.
That's beautifully
And few other things we are
demonstrated.
interested in OCT. We have implanted a 3.5 scaffold in a 3 SL distally, and it is you can just see here it is nicely confirmed. There is no edge dissection. You can see the reference vessel area is 5.35, and if you go up to this bifurcation point, the scaffold is very well expanded, and it is minimum area is 5.22. It is appropriate for a 3 millimeter vessel. And you go proximally also, the scaffold is very well expanded, and there is little malposition proximally, then you can just accept with that. So overall scaffold is well expanded, and then it has been crossed into the side branch appropriately.
Right, let's go
Could
to
you show
the angio, please.
Three-dimensional view. Three-dimensional. Please let him have a demonstration of the three-dimensional.
So post-dilated BRS with
Show
a
that
quarter
thing so
size
that
bigger
people
balloon,
can
or what
understand.
post-dilatation you did?
Show the wire cruising.
So you can just see the 3D OCT showing that wire going exactly in the middle of the side branch.
Actually, Dr. Srinivas, after this 3D tool did come to our lab about 2 months back, we really kicked about this, seeing the wire crossing the distal strut or the middle strut. It actually
very
helps
well.
us do the bifurcation better.
Yeah, wire is seen quite well, very well. And it is gone.
Yeah, next. Right. Next. Now let's come to the angio back, please. Now, in the angio, next angio, so what we did is, once we crossed, next, then next. Now we took a 2.5 balloon to the side branch, and we have kept a 3 in the main. Now, as Dr. Srinivas was saying, there are certain rules of BVS which you have to maintain. If you are doing a side branch dilatation, you should not go over 10 atmospheres, and when you are doing a KISS, you must not go over 5 atmospheres with appropriate size balloons. So that's exactly what we did. Next. 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 You're going previously. Next. No.
No. The next.
Scene minus. Scene minus. Scene minus.
Okay.
No. Go forward. Go forward. Yeah. Run.
Yeah. No.
That's opening the side branch. Next. And once we open the side branch, we kissed. That kissed is not there. Okay, right. After we kissed, I'll tell you. It's there in the kiss is there, seen very well in your IVUS Angio Plus. Now I'm going to do a shoot right now. Let's see what is the final result. So I'm going to just do a shoot and show you. Wow, the final result looks decent.
Not decent. It's good.
Oh, that's wonderful, Rony.
What do you say, Srinivas?
Yeah, we are able to see it well. I think
Dr. Hiremat, how are you, sir?
it has come out quite well.
Dr. Rony, do you think that the kissing will do damage to the VVS?
No,
has
I
not
don't know
done,
how
but
many,
has it the
yeah.
potentiality? Instead of kissing, if you go for the hugging, so whether that makes a
Yes,
difference?
see, there is this beautiful bench study. Yeah. No, see, there has been this good bench study that has been done by, I think, John
Orminston.
Yeah, so there he has shown very clearly that when you cross a BVS, if you're going to only open the side branch, if you go up to 10 atmospheres with a 3 balloon in a 3 BVS, you are not going to cause a fracture. So when you kiss, similarly, if you're going to use a 3 in the main branch and a 2.5 in the side branch, you go up to 5 atmospheres, you're not going to cause a fracture.
I think you have demonstrated excellently a combination hybrid technique, but just to prove
So you
itself,
follow the rules
but,
of the BVS, it's fine.
Yeah, I think you have an excellent demonstration. And congratulate all your team, and we'll go to the other place.
Any
Big round
plan
of
to
applause
check
for.
angiography later on?
Sorry.
Hybrid technique.
Yeah, so before I tell you, pardon?
Any plan to do check coronary angiography after 6 to 9 months or 2 years?
Yeah, before I
This is
sign
hybrid
off, let me
technique.
thank you for giving us the opportunity.
Okay. Yeah. Can you get Apollo picture?
Take it out, take it out. Take it out.
Rath, we are able to see you and hear you now.
Yeah, fine. See this, we have we have done implanted just take it out, just entanglement. Just give injection. Injection. Wait. Okay. See this, just show the steps. What we did is, we dilated the strut with a 2.5 millimeter balloon. Can you show it now? Just go then we went down and dilated the distal part of the circumflex. It was roughly around 18 millimeter. Then we took a 3.5, before 3.5 stent, 3.5 18 alpine stent, and put it little proximal to little inside the left main. Then took a 3 millimeter balloon into the left, from left main to LAD, and did the tap technique. Then after that, we inflated both, you see, and then what we did is pulled out both the balloon and did a kissing, and that is the end result. So just take one more shot. Go to the PA caudal.
That's why we are asking about the length of this.
18.
No, but just after that there is a tight lesion.
Okay, go to the PA cranial.
OM, just before the OM.
Inject. See, LAD looks fine. Left main is fine. So the circumflex.
Circumflex after the stent, can you image it better?
You know this. Can you just
see that.
little other view? You just put it, because we took a 3.5 stent in the circumflex. So
Take
just-
a caudal picture and
yeah.
image that circumflex well at the distal to the stent.
No, just go to the PA caudal.
Another lesion, OM. Yes.
Just give NTG, because if you look at the picture before, that area there's no disease.
was
I
asking
think
about
see
the length of the circ stent.
we'll give some nitro and take some shots and then decide what to do. But I don't think there is disease there. I think the spasm, we'll just check it, how it reacts to
It's not, it was
nitro.
in the beginning also.
Yeah, PC, probably I would leave it, I think
Let me
it's,
give some nitro and...
there was no disease and we don't see dissection.
but,
We're
we
lucky
can-
to get away, but probably if the stent has ended proximal to that LCX atrial branch.
No,
it
I
won't-
think
it would
stent
have-
has ended in the, see, this is the spasm. Look, this is the
I think
no
it's improved
disease.
now.
Yeah,
Yeah.
this is
Better.
this was spasm. So what I am going to do now, give me a where, if you have time, I'll do the IVS for the left main and LED, then we'll see whether it requires, is well opposed or it requires any other further dilatation. And as I told Hiramat, I think your suggestion of doing dilatation with the two balloon, we did it, and we did it in the ear also, so we'll just took the intravascular ultrasound. We did a stent boost also, isn't it? Can you show the stent boost? Show the stent boost.
So what you've done is a tap to the
Tap,
circ.
yes.
So if you had treated the circ before, was that a good idea?
No.
Or you wanted, if you had done
I was, the tightest lesion was circumflex, LAD, and I wanted to treat that first. And I think it was not difficult to cross the circumflex. It is not it was around 60
Angle is wider, no, so
Can you
that
show
is
that?
ideal.
So this is, you have time, I think, for a intravascular ultrasound run and catheter intravascular. We are using iLab, and this is Atlantis catheter from Boston Scientific, and this we have put, now we can image it. So, this okay? I think this is, okay, fine. Okay, fine, run it. I think I have time to show you the intravascular ultrasound result. Is it okay? Okay, fine. Strut is well opposed. You can see the struts now, no? Not yet. It is still in the LED.
See, I think choice of stent here, Alpine as a second stent to circumflex was a great choice because we all know that it sort of maintains
This is well
the
opposed, this stent.
coaxiality.
Yeah, then,
If you have already a deployed stent and you want to take another stent through it, I would feel Alpine has a great tip which can coaxial itself to get to the center of the wire. So there is no wire bias, or it can overcome the wire bias and get
that is across
into
the
the
circumflex.
position. So
It
it's
will
a
oppose
great
that
help
it needs
under
more
these kind
dilatation,
of settings.
well opposed, but there is some gap, I think, in the left main.
Proximal portion.
Yeah. I think it needs, it's in the left main, it needs little more dilatation. I am not happy with the position. I think we'll take a 5 peripheral balloon and dilate. Short. We have a 5 peripheral balloon.
When you do that, the balloon is going to be from left main to LAD.
Yeah,
So
inside
what
the
happens
stent.
to the stent which is already deployed? Are you worried? I mean, you must do it with a kiss or you just do with a single balloon now?
No, I've already done with a KISS. That is 3.5 balloons for the circumflex and 3 meter balloon in the LED. Both
is
I
up
have
there.
dilated. So still it is, so I think I'll take a cylindrical, one balloon, 5 millimeter peripheral balloon, and dilate in the left main.
Maybe short balloon only in the left main inflation should be done. It should not cross too much into this thing.
No, we'll inflate it inside the stent in the left main. Short balloon, if I get it, I'll take it.
Okay. Thank you,
Or
Rath,
else-
for the excellent demonstration. I was told that the time is up and demonstrated the bifurcation of left main stenting very well. I think a big round of applause to Apollo and Lisie.
Thank you very much.
Congratulate
Thank
you
you
all.
very much. Okay.
Thank you very much,
Thank you.
chairpersons and members of the expert panel. Ladies and gentlemen, that brings us to the end of the first twin live cases, which came live from Dr. Rony Mathew's Lisie Heart Institute in Kochi, and Dr. P.C. Rath was in action from the Apollo Heart Institute in Jubilee Hills, Hyderabad. We move on to the next session, which is on LMCA intervention. We will have 7 speakers. The first 6 speakers will be speaking for 6 minutes, followed by 2 minutes for a quick chairman's comment. And the last speaker, who also happens to be a chair, would speak for 9 minutes and 3 minutes for a comment. Ladies and gentlemen, as the scientific committee's decision is in place, at the end of 6th minute, the slides would be freezed and there will be no extension given to the speaker. So please bear the time in mind. And with these few words, I would like to invite confirm the availability of our speakers. Dr. Hiramat, our chairman, and the first speaker is very much here. Dr. Prem Ratan Degawat, yeah, he is around. Dr. Rishi Gupta, if you could kindly raise your hand and make your presence felt. Dr. Rishi Gupta. Okay, probably, ladies and gentlemen, as you're aware, there's a morning important decision that's been taken. Any speaker who doesn't come in the prescribed slot will be debarred from NIC proceedings for the next 2 years and will not be given any later slot in the course of the meeting. Dr. Pankaj Manoria is very much here. I hope he has loaded the presentation. Dr. M.G. Pillai from Mumbai. Dr. Pillai? Okay, probably we don't see him around. Dr. R.G. Bhagwat? Dr. Bhagwat? Okay, we will keep inviting the speakers in the order of appearance. If you fail to appear to deliver your lecture, we will not be given any further slots. And Dr. Jaspal Arneja, who also happens to be our chair. Dr. Arneja, if you could please make your presence felt. Okay, fine. Thank you very much. So with these few words, ladies and gentlemen, we are about to proceed to the next session. That's on LMCA intervention in a minute from now.
Yeah, just one.
Ladies and gentlemen, as we are pressed against time of only 8 minutes, at the end of 6th minute, it will be the prerogative of the chairman to make the comment. And if the panel of chair feels subject to time, we shall take any input from the floor, but that's purely at the discretion of the chair because we just have 2 minutes at the end of every presentation. To help our speakers be on time, we have a timer on the screen. Please pay attention. May I straight away invite the chairpersons, please welcome in the order of appearance, Dr. Jaspal Arneja, Drs. M.S. Hiramat and A.B. Mehta. Joining them as part of the expert panel, Drs. Brajesh Mittal, G.R. Kane, P.B. Jayagopal, Ramdev Yadav, Mohammad Shaloob, and S.N. Rautre. I'd request the members of the panel to please join along with the chairpersons on the dais. And we'll straight away move on to the first presentation that features Dr. M.S. Hiramat for the next 6 minutes, followed by 2 minutes of discussion on left main. Can we have Professor Mehta and Dr. Arneja moving on to the dais? I'd request the speakers to kindly stick on to the time as we are extremely pressed because after this session, exactly at 12 o'clock, we are supposed to go live to Paris for Dr. Jean Fajade's live presentation on BRS and bifurcation. Thank you very much, chairpersons. With these words, Dr. Hiramat for the first presentation on LM.
So,
Can
I start? Or?
Yes.
Okay. So, when we talk of left main, we of course talk of a lot of strategies. And when you have an ostial lesion like this, standard thinking is have a side hole to the guide catheter so that you don't wedge, large circulation is dependent. And then you predilate very strongly, either with a non-compliant balloons, but preferably with a cutting balloon. You can actually see we have put 2 balloons for post-dilatation in a hugging manner to get the ostium fully open. And this is how you end up the ostial locations. The shaft locations, it may look like a type A lesion, but never underestimate. Preparation pre-stenting has to be perfect, because if you post-dilate heavily, you could dissect, and the dissection could still be in the left main. So you must make sure that you prepare well, choose an adequate length stent. Sometimes it's stent length, which you must have in your shelf for these kind of lesions. But the real action comes when we talk of bifurcation of the left main. This is an acute MI. Best way under these kind of setting is do everything quickly. So a small pre-dilatation, stent in, and final result, LAD to left main, and don't worry about circumflex in a STEMI kind of situation. We have trifurcation here. You can see the IVUS at this point, left main to circumflex showed moderate disease. So when we want to stent, our first stent was to the largest vessel, left main to circumflex, second to the OM1, and third one going to the LAD, ending up with this kind of results. So when you have trifurcation at the distal end, you have to have some kind of strategy. So this is the CTO of the LAD, and once you get the CTO opened up, you need to plan. But here you can see a very, very large diagonal vessel. So when you strategize, our first stent was from ostium to circumflex, second one going to the diagonal, and third one going from here into LAD. And this is the kind of final result that you have on LAD diagonal bifurcation. So a strategy should be pre-planned. In this case, the stent diameter has to sort of match the left main. So we put the stent into ramus, primarily because ramus is such a huge vessel compared to LAD. So LAD doesn't matter, even if you're treating LAD as a side branch, but treat the bigger vessel for the stent to land in. In this particular case, actually there are 4 vessels. This is a recent closure. We do a pre-dilatation, so you kind of have 4 vessels. LAD is not critically diseased. So all that you do is make sure that you don't harm LAD when you are stenting here. So after pre-dilatation here, put 2 stents and a balloon dilatation to the OM1, ending up with this kind of results, always preserving or looking for a good flow to the ostium of the LAD. And then you many times have this kind of situation where left main is calcified. So the calcium actually seems to extend towards LAD more. In this particular case, my colleague actually, Dr. Mathew, preferred to use cutting balloon. So cutting balloon on LAD, cutting balloon on diagonal, and then a hug so as to achieve a good diameter on the left main, ending up with this kind of results. Mind you, this is a very acute angle bend from left main to circumflex, and one would probably avoid putting a rotablator in these kind of situations. In this particular case, again, a calcification in this area addressed with cutting balloon, but unfortunately the patient has a perforation. But mind you, the perforation is not where we had calcium at the left main bifurcation. It is a few millimeters distally into LAD. But all that it tells you and I is whenever you're dealing calcium in the left main, be very aggressive on debulking. It could be cutting balloon, it could be rotablator, it could be a bigger burst. First burr run may be a smaller burr and a bigger burr later, so that you can dilate adequately. IVUS very strongly indicated. In this case, we used IVUS, and then we decided the stent should not stop at the ostium of the LAD. It should be brought back to the left main. So the stent actually starting from the left main distality towards the LAD. In this particular case, IVUS indicated that the ostium of LAD and ostium of circumflex are free of disease. So our stent was limited exclusively to the distal portion of the left main. So starting from here and ending just before bifurcation, leaving ostium of the LAD and ostium of the circumflex free of any kind of stent. So this was another challenging case, an aneurysm of the proximal LAD. So DES from this portion to the distal LAD, as you can see here, and then a covered stent in the proximal portion, as you can see here. So we had to actually worry about the flow into the diagonal because this was a covered stent, and also worry about the flow into the circumflex on either side. It worked perfectly well. We had a good result. However, this is a BMS, and the patient comes back with restenosis. This was a year later, which was again addressed with DES in a T kind of fashion, giving us perfect result. This patient has moved from age 28 to age 49 with these 3 procedures. And then, since we are stenting so heavily in the LAD ostial area, the results of ostial location sometimes not the best. You have 2 stents placed in a V kind of fashion. Mind you, no stent was projecting into the left main. We have a restenosis a few months later, and now we bring in 2 stents, one going to LAD and one going to circumflex. So this was actually done live to India Live. We debated whether this should be a culottes technique, but there was too much metal, so we preferred putting T kind of stenting in this kind of situation. And then we have occasionally these kind of what we call as a man-made left main. This was vein graft joined to the side of the vein graft, and you can see both the vein grafts actually controlling the left-sided entire circulation. Again, a big diameter issue. We had to work very carefully not to allow any kind of distal debris to go in, ending with this kind of stent.
I'm sorry for the interruption, Dr. Hiram, we have totally run out of time for your presentation.
So this is the final result on the vein bifurcation. And so what I try to show you is many ways in which you can address the left main. But remember, we must end up with a perfect result. Thank you indeed for your
We just have 2 minutes for a quick comment from the chair before we move on to the next case.
Yeah, any questions from anybody of you? Jaspal?
Is there any role of OCT at the moment in left main?
Yeah, I mean, OCT would help, but most of the information can be obtained on IVUS too. So I'm not really convinced, because all that you need to know is diameter, calcium, and both can be accessed very well with IVUS.
Just a brief comment from you. When you are dealing with the lesions like left main, what is the role of a stent by IABP or actually IABP support ongoing?
I think for a conventional case where there may be a lesion complexity, but ventricular function is okay, I would probably not use IABP standby.
Should we do with IABP not present in the cath lab?
No, I can't imagine a scene where IABP is not
right.
present.
So I think.
Thank you, Dr. Hiram.
Right.
With the permission of the chair, we'll move on to the next presentation for 6 minutes,
right,
followed by 2 minutes for discussion. Dr. Hiram, if you could please join the chairpersons on left main stenting. Dr. Prem Ratan Degavat would be in place. Dr. Degavat, please. You've got 6 minutes for presentation and 2 minutes for discussion. To help you be on time, you have a timer straight across. Ladies and gentlemen, the lecture that comes up is on left main stenting by Dr. Prem Ratan Degavat.
Good morning, everyone. I am on behalf of Dr. Jitan Singh Makkad. I am presenting a case. A 45-year non-diabetic, non-hypertensive, non-smoker male with no significant family history, with a known case of right tibial osteomyelitis at non-cardiac surgery at other hospital, and patient developed cardiac arrest on OT table. with multiple DC shock and on CPR, patient was shifted to our hospital. At the time of presentation, BP was not recordable, pulse rate was 28 per minute, ECG showed broad QRS, sinus brady, and non-specific history changes. 2D echo reviewed global LV hypokinesia and EF 20-25%, and urgently TPI done at the bedside. And this is the non-selective view because there was difficulty in hooking the left system. So if you seen carefully, there is an oscillating flap seen in the left sinus. And after selective hooking, this is selective. This is very scary looking. This is a flap at the ostium. When we see carefully, there is thrombus seen in the left main. So our decision was to directly go for the left main stenting with the GL6 catheter, GL7 with thrombustor. So we directly hooked the left main, taken the LCX, cyan blue wire to LCX and with thrombosection. And unfortunately, we could not save the image of the post-thrombosection. And this is after thrombosection. We just take a Giants Pro 428, and after adjusting into left main, we deployed it. But as accepted, the patient goes into cardiac arrest. During CPR, the stent was deployed, and that was the result after stent deployment. We think there is chunks of thrombus in the left main, and next decision was to just thrombus the aspiration of the left main. And which, after thrombus aspiration 5 to 8 mm balloon, the left main ostium stent was dilated. And after dilation, this was the result. Again, patient under arrest. So when we next step was to thrombus aspiration with the thrombustor catheter. But because when we see that clearly, the left GL catheter is not aligning with the left main catheter. When we introduce the thrombustor catheter, a wire and thrombustor came out. So we have to change the catheter with XP 3.5. And after thrombosection, this was the result, with changing the catheter. And after that, with another wire, we dilate the LCX with 2.5 to 12 mm balloon. And meantime, this is the result after balloon dilation. Because the patient was very sick, we just we accept this result, and patient was shifted to ICU.
Did you get back the patient and check the result later?
The
next day?
Because the patient was on ventilator for 15 to 20 days, but patient goes, we have planned that we will go check the angio after in the follow visit.
Many times when you see so much of thrombus and you get them back to the lab after a day or two, you find the arteries flowing much better.
Yes.
I think this was very courageous from zero to wherever you achieved a big circumflex circulation. The point here is post-dilatation aggressively. Like when you put a stent, there was reasonable flow. And then you go with a 4.5 or 5 post-dilatation balloon. Most of the time, you will bring back the thrombus in the left main. So under these kind of setting, maybe accept reasonable result, not post-dilate very aggressively.
Thank you.
Can I make a comment, sir? Okay. This type of people who have cardiac arrest and gives you some sort of a time to perform an angioplasty. You got time to perform. So I feel that they usually have some support from the right system. So is it worthwhile doing a right angio because you did not see anything?
Because it was very patient had already CPR for 1 to 2 hours. We shifted to our hospital. It was very critical situation. We could not take the angio of right system.
Because that may be helpful to see how much the LED fills retrogradely. It gives you a lot of...
Because the patient was young, and we have seen that flap in the hostel. We think that RC would be normal. And in the follow-up visit, we have planned that the RC...
I would imagine whatever the right is, it's immaterial under these kind of settings. You have to go aggressively for left main.
No, I think one point which I want to bring to the notice of everybody here is that when there is a cardiac arrest, or even when the systemic pressure is very low, the counter pulsation with intra-aortic balloon pump is ineffective. It doesn't work. So I had once an experience after reading somewhere some case report. When we had such a situation, we timed the balloon pump with a cardiac massage beat. Whilst you are in the cath lab, you actually know that with your cardiac massage, you are generating 80 to 100 systolic blood pressure. You can watch it on the, and then a smart technician times these things, and then the intra-aortic balloon pump synchronizes in the pressure waveform, and we get some kind of thing. And you continue for some time, and then balloon becomes functional once the blood pressure improves. Apparently, it was a great case.
So you're not talking of a manual compression for cardiac massage, it's the
Manual,
mechanical one.
manual compression.
But you get those mechanical ones, you had any opportunity to?
No, I have not. But I think this kind of emergencies and all, I think to set up the automatic or a mechanical one, it's going to take still some few extra minutes, and every second matters.
So the mechanical ones can probably go for a longer time, do not obstruct your image. So you can continue balloon pump, mechanical compression, and continue with the angioplasty.
Yeah.
If there aren't any further questions.
And in case in this kind of a situation, what do you think of Impella? That I think is a great device. The systolic blood pressure is less than 40. The intra-aortic balloon pump is usually ineffective. Therefore, I think Impella is a great device. Excellent.
Okay, if that's the number of questions that we have, thank you very much, Dr. Tegabat. We'll move on to the third presentation with the permission of the chair. That's on left main angioplasty. I would like to invite Dr. Rishi Gupta for the next 6 minutes to help Dr. Gupta be on time. We have a timer below. Dr. Gupta, please.
Slide changer. This is next. And this is a pointer if you want to point.
Can I have the presentation? My presentation? Good morning, chairpersons and my colleague. Today I am going to present a case of left main trifurcation stenting. This is my patient, 79 years old male, presented with recent onset class 3 angina, and the examination was within normal limit. The patient was diabetic and hypertensive. Patient had anterior MI about a year back and had a stent in the mid LAD at that moment. ECG at that moment showed almost normal type of ECG. Ejection fraction was about 50%. And this was the coronary angiogram, which you could see that the RCA was small, diffusely diseased, and it was the LAD, and which had an ostial about 70% stenosis. One of the large OM1 or Ramus type of vessel which has a significant stenosis at the proximal part, and there is a ostial plaquing of left circumflex, and there is some disease at the LAD left main ostium as well. And this is another view that you can see in this areocranial view that there is some ostial disease of the left main, and which is not apparent in the aliocaudal view. And keeping in this view, it looked like that the disease is moderate and it's a complex anatomy. We initially planned that maybe we can keep the patient on medical follow-up. We said that let the patient be on medical follow-up, but patient continued to have class 3 angina, and the patient was readmitted again. And at that moment, we said, let us check the FFR, whether the disease is really significant or not. And then the FFR was positive, was 0.61 from left main. We checked in the OM. Then we said that there's something to be done because the patient is very symptomatic, and this is responsible for all these symptoms. And the RCA is really small. And then seeing this anatomy, that there is all 3 arteries which are diseased, I think the patient has to be tackled. All the system has to be tackled. And then the patient was, we asked for a bypass surgery. Considering the age, the patient refused for bypass surgery at any cost. He said he may die, but he will not go for an bypass surgery. Then we said, okay, we'll do the stenting of the left system. We crossed the wire to the circumflex and the ramus. If you see the angiogram carefully, actually I have not shown that picture, the ramus is not truly ramus, it is OM1 branch, and that is the very important point which made us that possibly that doing stenting will be an easier option. You can see in the second picture that this is the OM1 branch, that means that there is some gap from the LED ostium to the OM1, and that will make you safer, you feel better that possibly it will not be more complications while putting a stent in all three branches. Naturally, we said that how to do it, we made it simple, that the circumflex is a big branch. We did the balloon of the ramus, we passed the wire into the circumflex, and then ramus, we did the ballooning of ramus, and then after ballooning, we passed the wire to the LED as well, and then we put the stent from left main ostium to circumflex. This is 3 into 23 millimeter giant stent. After putting the stent, the pot was done to the left main with 4 millimeter balloon. And after the 4 millimeter balloon pot, that the simple tap technique was used to stent the ramus, keeping a balloon in left main to circumflex. And this is simple tap technique, and then the stent was inflated, 2.5 into 18 millimeter stent, and then the kissing balloon was done to left main to circumflex, and left main to the OM1 branch. Then again pot was done, and then, sorry, I think the one, yeah. In the second picture, you can see that once the stenting have been done to the left, to the OM1 and to the circumflex, then the simple stent was implanted by the technique to the LED, from left main to LED. This is 3 into 18 millimeter giant stent in LED. And after putting the stent, you had the pot to the left main. And this was the final result. The left circumflex is flowing well, the OM1 flowing well, and LED result was good. So it was, I think, looked like a complex case, but really speaking, it took maybe half an hour to complete the case, and it was really easier to finish the case, and unfortunately the patient did well, and his symptoms relieved. Now it's 6 months follow-up, he still has not complained any symptoms. We plan to check it maybe down the line after 9 months. My main worry is that the left main to circumflex band, which is more prone to have restenosis. I am cautious about that point of view. As Dr. Hiremat said, the left main angioplasty can be done using different techniques with almost equal results. And this case demonstrates simple tap technique to do the left main trifurcation, keeping everything simple with the good result. And of course, the other important part is that the angiography, most of the time, which I have seen that the assesses the left main lesion, under-assesses the left main lesions. In those situations, intravascular ultrasound and FFR is very important to assess the exact severity of left main lesion to decide about the further treatment. Thank you very much for your patient listening.
We just got one comment time for that, Mr. Chairman.
I think you're very humble. I think you say it's a simple technique, but I think it was a good strategy. And I think what helped you was your expertise. And I think I must compliment you. Excellent case. I think, Hiramat, any comments?
Yeah, I think what I liked is the length of the stent in the left main. I think you kept a very good length in left main, which allows you to do a good part. And part is key to success, to the distality of the branches coming out. So I think that was one good point. And the other thing is people used to do culottes, but if you see percentage of culotte across the labs, it has clearly gone down, because in these kind of situations, though culotte works, technically it is very challenging, and you are bringing in too much metal under these kind of situations. So very well done.
All the time that we
I just
have.
wanted to ask one.
Thank you
quick
very much,
question.
Dr.
Very
Gupta.
well done case, sir. Just want to ask Abhimata, sir, how often you, in view of so much metal load, how often we should do an angio to in follow up every 2 years, or how do you do, sir?
This is a specific case, and I think if you ask me the guidelines in the left main, doing an angio has become class 3 indication now. It's not recommended at all. But in this kind of a special case, I think it is operator based. If you are not comfortable, you should do in 6 months' time.
Okay, that's all we have time. Thank you very much, Dr. Gupta. We'll
Thank
move
you.
on to
Thank
the
you.
fourth presentation with the permission of the chair. That's on angioplasty in a case of total left main occlusion. I'd like to invite Dr. Pankaj Manoria from Bhopal for the next 6 minutes with 2 minutes for presentation.
Thank you, Chairpersons. This is a case of a 52-year-old gentleman, diabetic, a resident of Mumbai. He came to Bhopal for attending a marriage ceremony. And this marriage ceremony could have easily turned out into a cremation ceremony, but we say God is great. He didn't have any prior history of CAD. He was brought in an almost collapsed state in the emergency department in our hospital, profusely diaphoric, tachycardia, hypotension, low saturations. He was immediately intubated, an IBP was inserted. He was given several DC shocks for ventricular fibrillation. I quickly took him to the cath lab. This was the ECG at the time of presentation, showing ST depression in inferior leads, some elevation in AVR, AVL. So gross ST changes were present in the baseline ECG. Echo showed a global hypokinesia of LV with a poor ejection fraction. And this, the right coronary was normal. And the left shot was taken. Left shot was a beauty. There was hardly any flow in the left circulation. So I quickly, while I was discussing the angio with the relatives, he again had one episode of VF. So quickly went ahead doing an angioplasty to the left main occlusion, took an all-straw wire and inserted immediately and let it go wherever it was going. And luckily it went into the LAD, and then did a thrombosuction to the LAD. And immediately after thrombosuction, the things began to settle. The ECG improved, hemodynamics gradually became better, and the patient became relatively stabilized. This was the result after a simple thrombosuction, and then quickly did a pre-dilatation with 2.5 into 10 millimeter balloon, and then the stent was deployed, and finally 3.5 into 10 millimeter NC balloon was used to further post-dilate, and this was the result, immediate result after doing the angioplasty. And this was the ECG just after the procedure. Then the IVP was removed on the 4th day, ejection fraction improved gradually, and the patient was discharged on the 7th day. So these left main occlusions are usually fatal, and most of the patients do not reach the hospital, but timely cardiac interventions can save the life of the patients. Thank you.
I think very well done. Most of us would hesitate the way you started, but I think key is to get the flow. The moment wire goes, as you mentioned, any vessel is fine. Here it went into LAD, but moment you establish flow, you would see the patient stabilize, gives you time to think, regroup, and then plan your strategy. So very well done. Thromboaspiration in these kind of setting, what is the role? I think it's getting hotly debated whether it's going to be useful or no. I would use it definitely, but everybody agrees. Like in this case, the thromboaspiration catheter may not go down too much, just around the lesion, you aspirate and come out. The only care is you can re-embolize the same clot into the circumflex. So that care you must take. You must go on negative every time you're trying to push the thrombus aspiration. So if you take good care, I think thromboaspiration is going to be a very good help.
Can I make a comment, sir? Yeah, if we are doing thromboaspiration in such a case, one thing one must ensure, according to me, is that your guiding is well engaged in the left main and does not hang into the aorta. Because one of the danger of thromboaspiration is you bring it down into aorta and it gets embolized to the brain. So that's one of the problems which have been found in all thromboaspiration trials, that RC ostium you do and patient develops a stroke. So if you are doing thromboaspiration very close to the ostium of the left main or RCA, the guiding has to be firmly engaged so that the clot, at least by chance, does not. I would love to know what Dr. Mehta has to say on
I think I have never found a cerebral embolism at all, and I've been regularly doing thrombosuction.
Ostial.
Yeah. Now I'm talking about even in ostium.
There are a lot of case reports like that, sir.
No, I've also never come across embolus to the brain.
Not only that, but though there are the trials like total and test trials, and they are saying that you should not do it, but I regularly even continue to.
We do. We all feel. Yeah, I agree with you that.
Just a tip. What is the audience's opinion about thrombosuction? How many people have stopped doing thrombosuction? And how many continue to do? I think practically everybody continues to do that. I think so.
So trial or other data doesn't matter. What is your clinical experience is the key.
Yeah.
I think
one comment regarding thrombus.
In the Indian context, we are more thrombogenic, possibly. The younger patients that come to us, they are really thrombogenic. And in an ACS like this, thrombus aspiration, I think, has to be on board.
Yeah, okay.
Okay.
Yes, Rishi Gupta.
Dr. Manoria, you can give your comment in the meantime.
So all these trials regarding thrombosuction, they have compared thrombosuction versus no thrombosuction. But what we find is selective thrombosuction is definitely useful. It has saved lots of patients, everybody has saved. So these trials compared no versus every. It may not be useful in all the cases of acute MI. We do not use it in all the cases. We use selective thrombosuction in selective cases. In selective cases, does make a hell of a difference.
Yeah, thrombosuction, actually, what I devise is like a normal artery. Thrombosuction catheter works very well. But in arteries which are very big, then you need to have a bigger aspiration catheter. Like the left main thrombosuction which you were contemplating, I probably would have been good that the same guiding, if deep-seated, would have done a very good thrombosuction. And I have seen that just aspirating from the distal part, from the guiding catheter, and then flushing properly, then keeping it flowing well, then removes thrombus well. And in fact, in the large RCA where you have a lot of thrombus, there even the special the guide liner helps very much. You put the guide liner up to the thrombus, and then you then do the thrombosuction from the guide liner. It works very well.
Okay.
No, but not in this kind of cases.
I mean,
this is a different case.
It's a different case.
No, I fail to understand how guideliner will work.
The guideliners work very well. Actually, there had been one of the presentation in ACC. I saw that. And there was the operator who used guideliner very effectively and showed at least 5-6 cases. And there the guideliner, what he did, the large RCA, and then put the guideliner up to the thrombus and just do the thrombosuction from the proximal part. From the proximal part, and it was very effective. It makes the lumen very big.
Anyway, what Dr. Rishi was trying to say is the thrombus at the ostium, like in this case, left main, is so close to the tip of the guide catheter.
No, here, this case, it will not.
It will.
We've totally
No,
run out of time,
not
Mr.
this
Chairman.
case.
We
I'm
have to
talking
move on
about
to
the
the next
RCA, large
presentation.
RCA where you have distal thrombus.
Yeah, I'm sorry for the interruption, Mr. Chairman. In the
You
interest
see,
of time.
if you remember, when the MGuard stent came, which indicated that there is no need to do thrombosuction, even in vein grafts, or whatever it may be, or no distal protection device, more importantly. Distal protection device in the vein graft is class 1 indication. Therefore, when MGuard stent came, what were their arguments? A, whilst trying to introduce any device, including thrombosuction, there is some embolization takes place.
I'm sorry,
They said IVUS and intravascular imaging studies of any kind, OCT, they have shown that sizable amount of thrombus still is stuck to the artery or the target vessel. And 3, they said that you may end up estimating or underestimating the vessel size because of the presence of a thrombus. But MGuard stent is gone. I don't think any one of us is using MGuard stent. So I think the standard policy, as I see now, is to continue thrombosuction, don't overdilate, take the drug-eluting stent, deploy at a moderate pressure, and get out. Possibly, if you can, do a direct stenting.
I'm extremely sorry, Mr. Chairman,
in
because
fact,
we have a
both
live
the
coming up
things what we
at
discussed
12.
today
We
is
will have to
controversial.
move ahead
Okay.
with the next
We'll move to the next
presentation.
case,
Thank you,
but
Dr.
just to make-
Manoria. We move on to the next presentation that will have Dr. M.G. Pillai from Mumbai on mini crush technique in a difficult left main for 6 minutes, followed by 2 minutes of discussion.
As Dr. Pillai comes, what I wanted to say was both the things we discussed majorly today are controversial. Thromboaspiration has been under debate, and even use of IABP has been under debate. So we keep using it because we find it useful. But the data on IABP itself, on cardiogenic shock and others, the shock 2 trial and all has shown no benefit of IABP. So these are, I think
the shock trial also is under so much of comments.
I keep asking those people when they're present in conferences, if you have a patient, do you use it or not? Everybody is using it, but they still discuss that it should not be used. So I don't know what to interpret that thing.
Good morning, respected chairpersons, colleagues. This is a case which I am presenting, which was done in December 2015 at KM Hospital on invitation as a live case for the 90 years celebration of GS Medical College. I have majority of KM people on the dais. Now, here is a 63, this patient was shown to me in the cath lab, 63-year-old male patient, non-diabetic, hypertensive, 6 months history of effort intolerance, ECG showing healed inferior wall infarction, and 2D echo showing EF of 45% with inferior wall hypokinesis. Now, there is significant calcium in the left main, distal left main into the LAD. There is subtotal or total occlusion of the circumflex. We cannot see the exact ostium of the circumflex. Looks small vessel. However, we thought we'll look at it. I did an IVUS. Unfortunately, there is no data printed out from the IVUS. It showed heavily calcified artery, but the calcium is in the adventitia. There was some fibrous tissue and about 20% calcium at at a small area. So I did not do rot ablation. My strategy was debulking, and the lesion in the ostium of the LAD was significant. So we tried to wire the circumflex. It was extremely difficult. We tried with a Fielder XT that did not go through. And then we found that the vessel is slightly different in origin. And then we poked with Concus Pro 4.5, but 6.5 could be negotiated, but it went into a small ramus or an early OM. And that was, again, side branch was opened up and with a 1.5 balloon. After that, we could see that circumflex is fairly good sized vessel with a good large distal vessel. The angle appears to be about 100 degree, 90 plus. So then we prepared the ostium of the circumflex with, as soon as we saw the circumflex is going behind, we rewired that circumflex. And then we debulked it with a cutting balloon of 2.5 into 6 millimeter flextome, prepared the ostium precisely, and as the lesion was going backwards into 100 degree, we thought it was better that we secure the circumflex first and stent it. Now, we use the anchor balloon to prevent further projection into the circumflex. We thought of various techniques, whether it should be a double crush or it would be a T-stenting. We thought it will be a mini crush would be a better option to cover both the proximal and distal part of the circumflex origin. So we secured and stented with an Ultimaster 2.75 into 15. Then after cutting balloon of 3 into 15 in the LAD, in the osteoproximal segment, the left main ostium and the body was disease-free. So we decided to take it from the disease normal segment, a stent of 3.5 into 24, and that was the result. We did a pot. You can see the left main has been expanded adequately. There is enough compression of the edges of the stent. Then we did a pot. We can see just one layer of 1 millimeter layer of the overlapping of the stent. Then we did a double casing balloon, and that was the final result. Now, we have followed the footsteps, the basic principle of pot and reverse hooking into a circumflex multiple times for demonstration that day, and that's what we have done. It's very important that we do cross the circumflex through the last strut, if possible. That's what we have done. Now, the message we want to give to you is use of Conquest Pro 6.5 helped to enter the small ramus and early OM or the early OM, followed by a pre-dilatation with 1.5 into 8 millimeter sapphire balloon. Recoil following 1 millimeter balloon dilatation necessitated the use of flextome for optimization and preparation of the circumflex ostium. Circumflex has 100 to 110 degree angle at the origin, and hence a mini crush technique was used with an anchor balloon on the left main bifurcation. IVS findings confirmed a significant disease at bifurcation, ostium of the body and left main free. Though artery looked heavily calcified on angiogram, IVS revealed minimal intimal calcification at 3 o'clock position. Rest of the calcium was at the adventitia. Debulking done without rotablation but with flextome. Left main to LAD stent with mini crush of the circumflex stent was done. Recross with circumflex following pot using reverse hooking, and final kissing done with excellent angiographic results confirmed on IVS. The LAD showed an MSA of 11, circumflex was 6.2, and left main was 12.8. Side branch total occlusion is often difficult, and use of Conquest Pro with varying weight may be used. Dilatation of the small branch near ostium may help visualize the main vessel as in this case.
We just have time for only one quick comment because we have to go live.
Yeah. Govinda, Conquest 6.5, to my knowledge, I've never seen that. I think it's a Conquest Pro 9, Conquest Pro 12.
No,
and
we have 6, sir. I made a mistake of 6.5. I didn't want to change. We have 3.5, 6, 9, and 12.
Yeah. Okay, I think that's a new
I made a
thing.
mistake in typing, so I didn't want to say that.
Yeah.
I just wanted to, it appeared, you know, that when you did a pot technique, in fact, I want to discuss about that part.
Yes.
That when you do a bifurcation stenting, the main vessel stent selection is as per the reference diameter of the distal segment.
Absolutely.
And the reason for that is that all these things are directed towards the adequate final structure into the side branch. Everything is directed. And when you do a pot later on, you should always be proximal to carina.
In fact, this
That's
balloon...
a must.
Sir,
It appeared to me roughly that your balloon was crossing the carina.
into the LAD.
Yeah.
You look at this balloon does not expand at the tips. It expands preferentially at the central part. You look at the.
It was a 6 millimeter balloon?
No, you can't go back, go in.
I can't go
Sorry,
back.
Mr. Chairman,
Okay,
we have
okay.
to move on because
It's
we
okay,
have got the
we'll move on. I think
live coming up. Thank you very much, Dr.
It appeared, but when you said, I have to take your words, that you were proximal to the carina.
In fact, if you look at the picture, it is very clear that the central part of the balloon has expanded adequately. Both proximal and distal part is smaller.
Thank
you. This balloon is specifically used for pot.
Thank you, Dr. Pillai. In the interest of time, we'll have to move ahead with the permission of the chair. I'd like to invite Dr. Pillai's colleague from Mumbai, Dr. R.G. Bhagwat, to speak on LM crush stenting in calcified coronaries.